from the second.
Good afternoon, everyone. I hope I'm audible. I see that there are people are still joining. So I'm requesting that we could give them just 2 more minutes and then we'll start. Thank you. I think we should start. We've reached about 35 people. Good afternoon, everyone. My name is Nompumelelo Mpele. I'm from the University of KwaZulu-Natal and the nodal director of Usinga, which is one of the SAPRIN nodes. Very pleased this afternoon to be joined by Professor Ngayana, who will be giving us a talk that speaks directly on anthropometric nutritional status and focusing on dietary characteristics of urban adolescent and young adults that are taking part of on the ARISE network studies, which are called Nutrition and Dash. Professor Ngayana is now at the University of Pretoria and is the professor there at the School of Epidemiology and is leading epidemiology in action research there, focusing on life course exposures, community grounded health interventions, and also capacity building of African researchers. He, for quite some time, was with us at UKZN, which is where we, together, me and himself, were co-PI on the ARISE network. And thank you so much, Jablani, for agreeing to come and give us the talk today. We look forward to it. Welcome to everyone to the SAPRIN webinar. And I'm going to give the opportunity to him to give the talk, and then after that we can have a section to ask questions. Please note that the webinar is recorded. So let's just kickstart it. Over to you, Jablan. Thank you.
Yeah, thank you, Dr. Mpele, and good afternoon, everyone. Dr. Mpele, I'm still with you, right?
Yes, you're still with me, but physically away. Yes.
Yeah, no, thanks for the opportunity to share some of the work that it's ongoing at Usinga HDSS. I'm going to start as a sort of a background and talk about ARISE and what is ARISE, because this is the term that you will keep seeing. So ARISE stands for Africa Research, Implementation, Science, and education. It's a research network that was launched in 2014 to advance collaboration in education and in research activities in sub-Saharan Africa. It brings together 21 institutions from 10 countries. It's convened by Harvard University T.H. Chan School of Public Health and Africa Academy for Public Health, which is based in Tanzania, in Dar es Salaam, serve as a sort of administrative hub of all these sites. The map on my left shows the geographic location of these institutions and the countries where they are located. So as you can see, we have sites in West Africa, East Africa, and some here in Southern Africa that include us, the site in KZN. So the Arise as a network has three pillars. It serves as a platform for cutting edge research. We're focusing on maternal, child, and adolescent health and nutrition. A second pillar is on capacity building. We have a collaborative and multidisciplinary training, which involve partners in the global north, that is in the US and in Europe, mainly in Germany. And the third pillar is on sustainable partnership. The Arise Network is very intentional about establishing stakeholder relationship and maintaining those relationships, because we feel that the work that is going to be generated by the network, for it to have an impact, we need to have our local or national and international stakeholders working with us so that it can increase the uptake of the evidence that is generated by the work that's done by the network. So most of the research that is done by the network, as already mentioned, focus mainly on adolescent health and nutrition research, conduct systematic reviews, observational studies, and intervention studies, and I'm going to expand a little bit more in the upcoming slide about the studies that the network has conducted since it was established. This slide shows some of the work that has already been done and completed, and all those studies were observational studies. And as you can see, the period that it was conducted, Usinga wasn't established by then. So most of these studies, or all of them actually, were conducted before Usinga was established. Though the last study, the adolescent health and well-being longitudinal study, was conducted where Usinga is, but that was before it was officially set up. And some of the findings of these studies have been published in peer review journals, and then the information is there if you are interested in learning a bit more about what was done and what were some of the key findings from these studies. So most of my talk today is going to focus on ongoing studies, specifically two studies. One is called Arise Nutrient. Nutrient is a short for this long title. And these are three main aims of the Arise Nutrient: is to determine key adolescent health risk factors and intervention needs in HDSS or across all Arise network sites, and to design an adolescent nutrition fluency intervention in these sites, and establish the effectiveness and performance of sugar-sweetened beverage tax policies in African countries in reducing consumption of these beverages in adolescents. South Africa is one of those countries that have introduced these policies. Not all the sites in Arise network or countries where Arise network has sites have these policies. So there are, I think, about 3 or 4 countries that are participating in the last aim. Another study is called DASH. Again, DASH is a short name for this long title. And the aims for DASH are to identify nutrition-related NCD risk among adolescent and young adults, co-design nutrition, mental health, and sexual reproductive health intervention aimed at reducing some of the risk factors identified, and evaluate the effectiveness and of this intervention. So a RISE network, as I've already mentioned, we're focusing on adolescent, and you may ask yourself why. So at this period of life is a transitional period between childhood and adulthood, and it typically occurs between the ages of 10 to 19. The adolescents are experiencing rapid physical, emotional, social development. These are some of the significant changes that are happening: physical appearance, that include puberty, cognitive abilities, emotional regulation, social relationships. So there's a lot that is happening during this phase. Also, it helps to sort of think of adolescent in these stages as well: early adolescent, middle, and late adolescent, as it has specific changes that are happening at each of the stage. So Arise Network feel like this is an important group to focus our research on, particularly because we think that it offers opportunity for interventions. It is during the stage where some habits are established. So also the mental and emotional well-being, the young people are developing coping mechanism, and it can also be used as a stage to build self-esteem and resilience to cope with a variety of the challenges and changes that this youth is facing. And some of these, the impact has a long-term or lifelong impact. So I'm going to now focus on some of the work from these two studies that I've been focusing on. South Africa, as the site in these two projects, is leading nutrition. The other two focus of mental health and sexual reproductive health are led by other sites. So here in South Africa, at Usinga and Arise South Africa, we've been looking very closely in the nutrition and diet data that we are generating. So I'm going to tell you a little bit more about that. So what I'm going to talk about or the data or the results I'll be presenting come from these two studies. So we pull together the baseline data from these two projects. Our study population, adolescent and young adults, age 10 to 24. So both studies use random sampling, and it is stratified by age and sex. Wanted to have a balance in terms of age group and sex. So the total combined sample size of these studies is 3,201. So in terms of procedures, we have a very long questionnaire, and this questionnaire is administered by our trained field workers. So this slide shows you some of the domains and questions that we covered in this questionnaire. So collect social demographic information, age, sex, school enrollment, working, living, and socio-economic status of a participant. We collecting information on health awareness and behaviors, collecting information on physical activity, hygiene, injuries, nutrition. We're collecting information on dietary intake. We're also measuring height and weight and hemoglobin in the blood. We have section on mental health, substance use, and sexual and reproductive health. So the questionnaire is electronic, captures this real time. The field workers are using tablets. So I want to expand a little bit more on nutritional status, how we assess it, as I already mentioned. we measure weight and height, and hemoglobin. And then from there, we calculate the BMI and Z-score. And Z-score, we're using UK growth charts, covered the range of 0 to 23 years old. From hemoglobin values, we estimate iron deficiency, anemia, and adjust for age and sex. Dietary intake assessment, as I said, we collect data through food frequency questions. We have 25 food groups that we collect information on. 16 categorized as health. That includes vegetables, eggs, and proteins, and nuts, and other things. And then we have 7 unhealthy groups, like highly processed, ultra processed food, high in salt, and 2 unhealthy in high amounts, that is red meat and high fat dairy products. Then we applied the global diet quality score, which is a rapid point metric that's designed to assess nutrient adequacy and NCD risk. So the way that the score works, it assigns a score on these 25 food items based on reported intake, and scores ranges from 0 to 49. And then from that score, we create categories. When the score is less than 15, it's considered high risk for NCDs, and 15 to 23 considered moderate risk, and a score of 23 or more considered low risk. So in terms of the statistical analysis, some descriptive statistics, it also assessed the association between the global diet quality score, high risk, and socio-demographic factors, and we estimated prevalence ratios to measure this association. And all the analysis was conducted using data. So I'm going to get into the results. This table shows socio-demographic characteristics stratified by sex. Highlight a few things here in this table. Most of our participants are in school. Overall, over 71% of the study participants are in school. And we use a subjective social scale to assess socioeconomic status. And this is chosen because most adolescent or young people, they may not know about metrics that are used to assess socioeconomic status in adults, like their parents' income and other things that are used to assess. So this scale was used because of that. And majority of our participants identify being in the middle in terms of the socioeconomic scale. Over half of the participants own mobile phones, and majority of them have reported using social media. We asked about different social media platform, WhatsApp, Facebook, etc. We've also asked questions around the parents' education level, and I want to mention this. Some of the participants don't know their parents' education level or status, and those that have reported their parents' education level reported their parents having most of them having secondary or achieve secondary level education. So these are the results on nutritional status, stratified by age group and sex. On the left, this is the BMI, body mass index, and as you can see, there is an increase over age in terms of the BMI, and females have higher BMI compared to males. On the right is a BMI adjusted for age, and what is shown there is a Z scores. And I think what's important here is to note is that there's evidence on the males of underweight, thinness, but on the females, evidence of overweight trending towards obesity. These are proportions of those who have anemia, again, grouped by age and sex. And again, it's evident high level of anemia, particularly in females. But there seems to be a trend of decreasing as they grow up. Not sure yet what explains this, but the high proportion of anemia in females is of great concern. These are categories I explained earlier. Diet quality. As you can see, these are shown by sex. There seem to be no different in terms of the categories across sex. But these results indicate poor diet quality. these categories now further stratified by age groups. There's some variation across the age group, but not significant. As I mentioned, we also looked at whether what are some social demographic factors that are associated with high risk scores. What we show here is that the socioeconomic status that I explained earlier and food insecurity household is one of the key factors that are associated with high risk score for NCD based on the diet quality. Summarize these findings, there is evidence of double burden of malnutrition. We see underweight in males and obesity in females, high prevalence of anemia, and females seem to carry the most burden of anemia. And also see that there is evidence of poor diet quality in this group, indicating moderate and high risk of NCDs. With insecurity and socioeconomic status were among key factors that are associated with this high risk. So that's what I wanted to share, and the work on this project is ongoing. The current activities that we're doing right now is developing interventions that are going to address these risk factors that we have identified as being key. We have done the code designing and of the intervention addressing these nutritional and diet issues. We are at the stage now where we are pilot testing some of these interventions, and the next step is to test if they are effective or not, and the findings for those will come at a later stage. And I will stop here and hand back to Dr. Mbele.
Thank you so much, Jabulani, for that presentation. Appreciated sharing this work with the network. I'm opening the floor up for questions and comments. Rupa, I think you did inform me that there were no questions that were submitted ahead of time. So anybody, the floor is open. You can raise your hand, and I will take questions. Thank you, Jabulani.
Pleasure.
Andre, please go ahead.
Uh,
Thank you.
Thanks, Jabulani, for an interesting presentation. I'm just curious about your comment about the anemia in the adolescent females versus males, because and you said you weren't sure like what's driving that, etc. But we know that women generally have, especially for iron deficiency anemia, that it's higher in women compared to men. And so, is that not? Is it really that unexpected that there's that difference between male or females, or is it a statistically significant difference that you're thinking about? And also, like one of the issues is around, like you mentioned about like socioeconomic status and food security. And is there a difference between the food security in the females versus the males? Because there might be like sociocultural um, issues around that the quality of the calories and the type of calories and the type of protein that women are eating, that there might be a difference between men and women, which would explain, because we know that anemia is purport directly related to the type of protein that we're eating. Thanks.
Thank you, Andre. I'm gonna let me take
Yeah.
maybe two or three questions, and then I'll hand over to you, Jabulani, if that's okay.
Because we have more time, can I respond?
Okay,
Because before I forget.
sure, go ahead.
So the first question is the difference in anemia prevalence between males and females. Yes, I agree that that's expected. What surprised us is really high prevalence. And so we're still looking into data of what other things could explain this, but because even if you look at the quality, the diet quality, like most in KwaZulu-Natal, there's very high intake of red meat and vegetables that are rich in iron. And we've seen in the work that I presented here, but there's still very high prevalence of it. But we know there's the biology and difficulty even in absorption, even if you eat food that is rich in iron, absorption in the gut can still be a barrier. So there are a lot of some of the things that I don't have data on that to explains what we have observed, but I've just presented the numbers. Your question of whether it differs by socioeconomic status, we haven't seen that difference. So there could be other things that are explaining this difference. We don't have answers yet.
All right. Thank you, Jabulani. Lucanio, please go ahead.
Thank you, and thank you to for the wonderful presentation. I just want a quick question. If I heard correctly, I think Jabulani mentioned that they used UK references to generate the scores. Can you explain why the choice of using UK versus the WHO growth references?
Those UK are WHO. So the WHO references are either UK or US. And the choice here is that the US ones, the range is 0 to 20. I chose the UK because UK is up to 23. And as you have seen, our study population is age 10 to 24. So that was the reason of choosing the UK growth chart versus US. And they are both WHO references.
Okay, thank you. Thank you, Lukani. Miranda, please go ahead.
Okay, thanks. And thanks, Johanny, a long time. Yes, so two, I guess, questions, comments. In terms of, using BMI for measuring adolescent, levels of obesity, is that necessarily the best measure that we can use? If you think about it physiologically, they actually, in fact, girls are expected to gain weight because of the changes from, being children to adults. And therefore, one would actually expect, some gain in weight. And therefore, when we classify them as overweight or obese, is that the best measure? I know people have used, for instance, mid-upper arm circumference as a better measure for so that's one comment. And then the issue in terms of anemia as well, I guess one wouldn't expect the population that you measured to be. So, for instance, for girls, during the menstrual cycles, they may actually appear as anemic. And that may affect the proportion of people that you say are actually anemic or not. But I would expect, if at any given time as a cross-sectional sample, there are some girls that are going to be at that point and therefore may be sort of misclassified. But I thought, it'd be quite an interesting observation. Thanks.
No, that's it, Mike. Great to hear from you. You are right. There's a whole larger debate about using BMI as a measure, like even in weight and other things. I agree, it's not a perfect measure. In our study, we also didn't take other like anthropometric, like waist measurement and so that we could look at other indices. So the BMI was the only indices that we could use, and I agree with you that is not the best. It's not the best measure, but I think it's because it's easy to measure versus using other things. On the issue of anemia, I also agree with you that these are physiological differences and events that are happening affect adolescent girls, and the timing of when we take this measurement could maybe also impact. I must admit that we don't have a way of, we didn't measure whether, we didn't ascertain whether the time of measuring this, whether the girls were on their menstruation cycle or not.
Yeah, sorry, through you, Chair, just to add, I guess my suggestion would be, if you look at mid-upper arm circumference, for instance, it's not a complex. You don't need something complex. A tape measure can be used. So you could actually sort of introduce that. The other one that people use that may be a little bit tricky is the skin test, to actually measure fat. But as consideration, going forward. Yeah. Sorry, thanks.
Yes. Yeah. No, it's a great point. It's just like with I agree. The tape measure is something that we could add, but it's something that we didn't do. Also, and also the way that and Dr. Mbele can also chip in here is also like that we're doing it's a household data collection. So we have field workers going there, and that means training them on doing all these assessments. And we have picked up few things, and they're getting better as they repeat these measurements. So yeah, I think it is a consideration, especially like the waist circumference. I think it's something that could easily be done, but we'll give Dr. Mbele's if he has anything to add on it.
No, I think it's a very good idea. Certainly, we really appreciate this kind of submissions because we could consider it and see how, especially with field workers now that they're advanced in the rounds. So yeah, I think we should talk about it. Thank you, Edmo, for that. Ali, please go ahead. Thank you.
Apologies for that. So firstly, hi everyone, I'm Ali. Andre knows me, and I declare an interest, and thanks Jabulani for your presentation. So my background is pediatrics, but also nutrition. I've got a raft of questions, but I think I want to suggest that I can engage after the webinar. But just a few points. Jabulani, in your slide of methods, I don't know which number it was, but on the right bottom, it talked about the questionnaires, about have you ever in the past 30 days used tobacco and so forth. It's something small, but it talks about illegal drugs. So that almost presupposes that tobacco is an illegal drug. But to move on about anemia, my question is, how was this measured? Was it by capillary blood, venous blood, and what instruments were used? And I just want to add about the males and females. It is expected, but again, and I'll stop now. Earlier on, or one of your early slides talks about iron deficiency anemia. One can assume, depending on the context, that most of the anemia would be iron deficiency, but unless one does extra tests, you cannot be sure of that. I'll stop there. Thanks, Jabulani.
Yep. Yeah, thanks, Ali, for the questions. Yeah,
No, it's not that one. It's probably
this one.
There we go. Under 5.
So yes. So the questions we ask about tobacco use, alcohol, and other illegal drugs. So yeah, the language there, yes, it's something that we could maybe correct. Yeah. So on what we use HemiQ. So it's a finger prick. And there's a picture of the machine that we're using there, and then read the readings. So so because it's field workers, again, this is partly a sort of logistical thing that we're using field workers. Field workers also they're not clinicians. So, but they could do the finger prick and use the MEQ to measure hemoglobin. So that's how it was done. I'm not sure.
Yeah. Thanks, Jabulani. And again, I'm prepared to talk later on.
Yes.
But
yes.
A lot of this method, or most of the methodology, is known, but also the negative aspects, for example, of excuse me, of doing HemoQ, either getting raised or lower results and so forth. So South Africa has done a few demographic health surveys, the last in 2016, where hemoglobin was measured, and we got a very high, this is now in the younger children, prevalence of anemia, and it's most likely that it's because of the methodology. But we can talk later, but it is important if one reports prevalences that one is assured of the methodology. Thanks.
Okay. Yes, I will look forward to interact with you. Thank you.
Yeah, certainly. Thank you, Ali, for that. Any further questions or comments? I don't see any further hands. Andre, please go ahead.
Thanks so much. I was not so much a question as I think it would be interesting to look at how the results compare to some of the other national surveys that were done, especially the the food and nutrition survey that recently came out, because I think give or take the methodology that you used is quite similar to what they did, and so it makes, from a methods perspective, it makes it easily comparable. And because I was just glancing through it and looking specifically at KZN's results, and I think that it might be interesting to see how it compares, or the two compares. Thanks.
So what is the name of that survey?
The National Food and Nutrition Security Survey.
Oh, okay. Have a look. Thank you.
Yeah, I mean, Jablan, if you want, I can link you up. I was part of the investigation team in the HSRC on that.
Oh.
So I can link you up with people in the HSRC if you need any data. And
okay, cool. Yeah, you owe me a meeting anyway, so
I will definitely.
cool. Thank you.
Okay, cheers.
All right, thanks, Edmund. Yeah, we still have a few more minutes left. If there are any other questions or comments. Ali, yes, please go ahead.
Thanks, Mpumelelo. And I apologize. It might have been mentioned at the beginning, but I don't know this population that was surveyed. Where are they exactly?
They are at Usinga HDSS at Umlazi Township in Durban.
Okay, thanks, Jabulani.
Thank you. I don't see any further hands. Yeah. Thank you so much, Jabulani.
Thank you.
For giving this presentation, and actually for also showing us some of the very important aspects of adolescent health and well-being in Umlazi. And we'll really look forward to the results, how the interventions are going to go, and be able to see if they'll make impact and how that would go about. So thank you so much for that. And I want to also thank SAPRIN for creating this fantastic platform. And thanks, Ropa, for organizing this webinar. Yeah, so thank you so much. And thank you everyone for participating and listening. As Ali said, open for engagements and I think Jablani's email address can be found in discussions. We value any kind of input and engagement. So thank you so much, everyone. The end.
Thank you. Bye-bye.